you do? Would you treat her? Would you give her daily treatment with low-dose aspirin? Or would you give her daily treatment with prophylactic doses of aspirin, heparin plus low dose of aspirin? Optimal management is still uncertain, but generally it has been recommended because evidence-based medicine suggests that if you have a patient who has SLE and she is pregnant, but she hasn't had any thrombotic episodes before, you would give her aspirin. Actually, it is recommended for all SLE patients to be on aspirin who are asymptomatic but have antiphospholipid antibody syndrome. So again the same, non-pregnant, antiphospholipid antibody is present, you could opt for a daily aspirin. When do you admit the patient? With massive DVT, just as we talked about catastrophic anti-lipid antibody syndrome, symptomatic pulmonary embolism, you have to heparinize them fully and then start warfarin simultaneously. You know the problems with heparinization and anticoagulation. There is high risk of bleeding, and there have been a lot of debates about whether you're going to do high intensity anticoagulation or low intensity anticoagulation. High intensity anticoagulation is when you maintain an INR of greater than 3, and moderate degree of anticoagulation is when you maintain an INR between 2.5 to 3. And now generally it is recommended that you would not need high intensity anticoagulation. When I was a fellow in training, we used the papers which came out favored high intensity anticoagulation for major thrombotic events, but now it has been shown that you can use moderately high intensity anticoagulation, which is an INR which is between 2.5 to 3. And you have to make sure that patients who, we are also taking with other comorbid conditions, and patients get admitted into the hospital. So just another thing, what are the challenges? The challenges, I'm sure rheumatologists who are here, the problems are monitoring of such patients and INR. It's sometimes very difficult because patients who are on warfarin, you might have difficulty in monitoring an INR. One lab gives you an INR of 5, another lab comes out and gives you an INR of 2. And it has been shown that if you try to do the INR at the same time of the day and with the same laboratory, it helps to avoid that problem. And there are certain medications which also, alter the INR. And surprisingly, one of them is paracetamol or Tylenol, so which does interfere with the monitoring. So it has been recommended that you should not use probably Tylenol on the day when you are having INR, which you usually do once a week or once a month, depending upon what's the frequency. What about the pregnant patient? We already discussed about the pregnant patient. We have to have OBGYN colleagues, and we have to have rheumatologists taking care of such patients. And we must make sure that hypertension is properly controlled. Lupus patients have hypercholesterolemia. They have coronary risk for coronary artery disease. These are patients who have high risk for developing thrombosis. So we have to modify their risk factors also. We just did the prophylaxis for asymptomatic patients. What is the duration of therapy? How long do you treat them? Actually, if a patient has had major organ involvement or major thrombotic event, they have to take anticoagulation for the rest of their life. What do you do if your patient is going for hip surgery? So generally the recommendation is to give them heparin just an hour or 2 hours before surgery and resume anticoagulation after 24 hours. Treatment failures, that depends. Recurrent thrombosis, what do you do? That's a difficult problem. High intensity anticoagulation is warranted in such situations, and maybe an INR greater than 3, but very close monitoring. And intensity of coagulation we already discussed. A few slides, just the last ones. They have been on the management of reproduction failure in antiphospholipid antibody syndrome. It's very interesting because people are thinking that these antiphospholipid antibodies may be responsible for infertility because they interfere in the deposition of the fertilized ovum in the placenta. So we should start looking at this also. So improving management of pregnancy in antiphospholipid antibody positive women is a great challenge. And these are twins delivered successfully in pregnant women with antiphospholipid antibody. So if we are vigilant, I'm sure we'll about 60 to 70% of the pregnancies are successful. This is a report which I thought was very interesting because we are all using Embrin and etanercept, and there were like 6 or 7 patients who were reported to have venous thromboembolism, and they were on etanercept because we know that etanercept can cause an antibody phenomena in which you can have antinuclear antibodies and other antibodies, and these patients were positive for antiphospholipid antibodies. So one thing to remember, there are experimental therapies, and I think the most interesting would be rituximab. The other is stem cell transplant, but rituximab has been used in patients who have had thrombocytopenia, which is very difficult to manage, and IVIG we all know about. I think that was fast enough. Thank you so much.